Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. And I recently got some questions from viewers posted on my channel that were quite interesting, and I thought I'd use them for this video. As usual, everything I say reflects my own opinions based on my own experience and study, and not the opinions of the Social Security Administration or any other medical body. So the first question was, during the consultative examination, do you show the doctor your problems, or do you just talk about them and how they make it hard for you to work? Well, the answer is you should do both. Consultative exam consists of taking what we doctors call the patient's history, which in terms of a Social Security exam focuses on the patient describing the medical problems they have that make it difficult for them to work and explaining how those problems make it difficult to work. And then the second part of the consultative examination is doing a physical examination where the doctor looks at and listens and feels the patient's body. When I do a consultative exam, I always focus first on the problems the patient has now that are making it difficult for them to work. And sometimes it's difficult to get the patient on board with this. It's important to know that Social Security wants to know what's wrong with you now that makes it hard for you to work now, and for you to explain how your problems make it hard for you to work. And it's best to describe your problems in your own language. Don't borrow the language of doctors or other healthcare professionals that you've seen. For example, if you're troubled by back pain, it's best to tell the doctor, my problem is that my low back hurts. It hurts if I bend over like this. It hurts if I walk more than 10 minutes, etc., etc. Don't tell the doctor, my problem is that I have 3 bulging and 2 herniated discs in the back. That isn't using your own language. It's also important to focus on what's going wrong now. You can give a brief history. For example, my back pain began 8 years ago when I had a fall. I've had injections, I've had epidurals, I've had a lumbar fusion, but I still have a lot of pain now, and now it hurts when I do A, B, and C. Some patients want to tell me the whole story from 8 years ago, every doctor they visited, every treatment they had. That's not really necessary, and we don't have time for it. What Social Security wants you to focus on is what's wrong now. Sometimes I tell folks, imagine if somebody called you up today and said, I have a job for you. You can come in tomorrow at 8 a.m. Why would you tell them you couldn't take that job today? After you've talked about your problems that are making it hard for you to work, I'll ask some general questions, such as list any and all operations that you've had and what sort of medicines are you allergic to, etc. They're of secondary importance. Once the history has been taken, I'll do a physical exam. For every patient, I do a complete head-to-toe exam. I do a more detailed examination of the body areas that they're complaining of, but I do at least a basic exam of every body area. For example, if a patient is complaining of trouble with their low back and both their knees, I'm going to focus on the back and knees, but I'm still going to listen to their heart and lungs. If the patient is telling me that they have shortness of breath due to congestive heart failure, I'm going to focus on the heart and lungs, but I'm still going to do a brief check of the back and knees. There are two reasons for that. The first reason is Social Security wants it. And the second reason is I find things. There's an old saying in medicine, if you don't look, you won't find. And I've found problems that are related to the ability to work that the patient never mentioned. And I've also found serious medical problems not related to the ability to work, but that the patient needed to know about by doing a general exam. For example, while examining a patient who was complaining of back and shoulder problems, I heard a very serious sounding heart murmur, and it turned out that the patient almost certainly had a condition called aortic stenosis. And the patient was likely to die from that aortic stenosis if it wasn't fixed in the next year or two. Aortic stenosis is fixable by heart surgery. That patient, I believe, needed the heart surgery, and I sent him out with a note to take to his doctor explaining what I'd found. I did a day of Social Security consultative examinations last week, and I was examining a person who had several complaints, but they had never mentioned their hands. When I looked at their hands, it was obvious they had a problem called Dupuytren's contracture, which is a thickening and scarring of the fascia and tendons in the palm of the hand that makes the fingers curl up and makes it impossible for the patient to completely straighten out their fingers. That affects three things that Social Security is always interested in: the ability to lift, carry, and handle objects. So that patient had a limitation for all three of those things. And if I hadn't looked at their hands, I wouldn't have been able to add that to their diagnosis list. I want to emphasize that a Social Security consultative exam does not just involve talking, and it does not just involve only looking at the area that you say is a problem. I have heard, I haven't verified it, but I have heard that there are some doctors who do these exams in 5 minutes. It's impossible to do a complete consultative examination in 5 minutes. The doctor must talk to you about your work-related problems and must examine your whole body. If that isn't done, I would contact your Social Security person. The next question was about rash, and you may be surprised to learn that Social Security will grant a disability application for certain rashes. The rash has to be severe, and it has to cover a large percentage of the body. I had one patient who had very severe psoriasis, and it literally was from the top of their head down to their feet, covering virtually more than 90% of their body's surface. So if you have a bothersome rash, that does count. Now, there were two questions also raised about this issue. The first is, should you bring in pictures of the rash? Well, if the rash is present, I would say no. I would like to look at the rash myself. Pictures may be helpful in two circumstances. One is if the condition comes and goes. For example, last week I had a person who had gout, which is a form of acute arthritis, that would give him episodes where his ankles or knees would become very painful or swollen. However, he was not having an attack of gout when I saw him, and his ankles and knees weren't painful or swollen. In a situation such as that, a picture of a swollen ankle or knee would be helpful. The other situation where a picture might be helpful is if a person had had a severe injury and had pictures of the injury when it first happened. Now, 2 warnings about pictures. The first is, I always shudder inside when patients tell me they want to show me pictures, because here is what happens 99% of the time. The patient gets out their phone, goes to their pictures, and then they scroll, and they scroll, and they scroll, and they can't find the picture, so they scroll some more. Folks, please, if you're going to want to show some pictures to the doctor before you go to the exam, select the pictures and put them in a folder labeled Social Security exam. That way you can have them available within 5 seconds. The second thing is, people who've been in auto accidents want to show me pictures of their damaged car. I worked in a trauma center emergency department, and I found that there's very little correlation between the damage to the car and the damage to the person. I deal with damage to the person. A body man deals with damage to the car, and pictures of the damaged car don't really help me. Also, if you did have injuries, it really doesn't help for me to see a picture of you wrapped up like a mummy in a ton of gauze, because I can't see the injuries. I would suggest you only have a maximum of 4 to 6 pictures, and that they clearly show the problem on your body that bothered you or is bothering you now. The next question was, what if you have a problem in a private area? And that's a good question. And here's what I tell patients. Social Security does not make anyone get undressed for these exams. However, if you have a problem in a private area, it helps your claim if I can see it. If it's a male, I have them undress if that's okay with them. If it's a female, I bring in a female medical assistant and have them undress if that's okay with them. Nobody's required to get undressed if they don't feel uncomfortable. I've had men and women with problems in private places, and so far, when I've explained things like that to them, I've never had anybody refuse, and it's very helpful if I can actually see the problem rather than just have the patient describe it to me. The next question was, what about wounds? Folks, wounds are very important to Social Security, and here I'm talking about wounds that haven't healed, that are open. Open wounds require special care. For example, the person can't get them dirty or wet, and that eliminates a lot of jobs. I had 2 patients last week who had diabetic ulcers on the soles of their feet. If you have an open wound, it's very important that I get a good look at it. I can describe the size, whether it appears infected, and how deep it is. However, one thing, if you have a wound that's covered with bandaging material, please bring some extra bandaging material to your exam. For example, the office I do Social Security consultative examinations in has no facilities for dressing material. And if I must unwrap the patient's dressing, I need clean material to rewrap it. The final thing that wasn't a question, but it's a problem for me often, so I'm going to bring it up, is bringing a second person into the exam room with you. For me, that can be a blessing or a curse. Now, there are certain situations where it's very helpful to have someone close to you come into the exam room. For example, if you are unconscious, for example, having seizures, and you're unaware of what you do during the seizure, if you have a friend or family member who can describe that to me, it's very helpful. Some patients have been in the hospital in the intensive care unit, sedated or in a coma, and in that situation, it's very helpful to have a family member or friend describe what went on in the hospital. Some people are confused. For example, they've had head injuries or strokes. Some people have lost their memory. Again, head injuries, strokes, other neurological conditions. And in all of those situations, having another person to help with the history is very useful. However, here's where it's a detriment. For every patient that I see, I have to evaluate their mental faculties. That means, can they think? Can they concentrate? Can they remember? Can they speak? Can they interact socially? I can't assess those things if somebody else does all the talking for them. And from time to time, I'll get an extra person coming in the room who wants to answer every question that I ask. Folks, please avoid that. If I need help, I'll ask the second person in the room. If you know the person you're accompanying is confused, please let me see that and evaluate that myself before I start directing questions to you. Again, I need to assess the mental capacities of each person that I see. Believe me, I've assessed many people with all sorts of mental capacity problems, whether that be from psychiatric illness, brain problems, other physical problems affecting their memory and thinking. And that's crucial for Social Security to know. Well, I hope this has been helpful. If you have questions, please put them in the comments and I'll try to address them. And always remember, if it happens, it's possible.